Okay. Since the session is about procedure punya presentation, and obviously procedure punya presentation is not it's not best to do it online anyway. So you need to see and at least observe or assist before you doing it. Obviously, you guys coming back tomorrow to the campus, and so hopefully you can get more in terms of observation of procedure in the hospitals once we clear up your quarantine and so on. But for the time being, procedure presentation is just going to be the way of doing things step by step and try to do it with, we call it aseptic technique. If you're doing lumbar puncture or you're doing any procedure, you need to do it as sterile and as aseptic as possible. So I requested Adila and tried to do probably 3 procedure presentation today, and then we're just going to go through bit by bit. And if you guys got any question, then we can talk about it. It's not ideal, but this is the way that we are going to do it for the time being. Okay. Right, who's going to start then?
Today we are 3, so we'll start with Shaira, and then Abi, and then Mike.
Okay. Right.
I to project myself. Okay, so Bismillahirrahmanirrahim. I'm going to present regarding the venipunctures and peripheral cannulation in pediatrics. So first, we're going to look at the venipuncture procedure. So we're going to go through the indication, what equipment need, and the site selection for the venipuncture procedure as well as the complication. Next. Okay, so basically the venipuncture is a procedure in which a droplet of blood from the patient veins to obtain a blood sample. Okay. So the equipment needs, we know that we need a glove and then we need a needle, which is a 20 to 25 gauge size, or scalp needle, and we need alcohol swab, tourniquet, and cotton. Okay, these are the pictures regarding the size for the needle needed for the venipuncture. Usually we use the yellow for the pediatric patient. Okay, so the site selection for the pediatric. So usually the most common site will be the median cubital vein or median cephalic vein. Basic vein and dorsal hand veins also can be acceptable. However, in the newborn, the heel will be preferred using the sterile blood lancet. I think it's most for the newborn screening. For the heel just now, you need to puncture at the green area and try to avoid the central part of the heel because it can might injure the underlying bone. Okay, next. So I prepared a video. So I'm not sure. So basically this video is a procedure or steps for the venipuncture in the pediatric. So first we need to do the second technique. Okay. Then we need to palpate the vein, select the site to be punctured. Make sure you need to hold the hands firmly in order to stabilize the vein. So make sure the bevel is facing up, and then the angle must be 15 to 25 degree angle. And then once we see the flash from the sample, like the blood sample. And then finally gently remove the needle and take the cotton. And don't forget to dispose the sharp needle into the sharp hole. Okay. So that's for the venipuncture. So this one is venipuncture at the side of the intercubital fossa, which is at the median vein, median cubital vein.
Back very slightly on the syringe and then continue to hold. Let the syringe slowly fill. Be patient. Pulling back too forcefully will collapse the baby's tiny veins and you will not get blood. Draw up the amount of blood you need. Release the tourniquet. Remove the needle and cover the site with a cotton ball. Fill the labeled tube and safely dispose of the needle. The third way uses a sterile butterfly device. This is more costly, but like the needle, can be easy to maneuver.
So this
Find a
one
good
is
vein
using the scalp vein.
and tie the tourniquet so you can easily release it. Carefully clean the skin and let it dry. Hold the skin firmly and insert the needle. Move the needle slightly until you see a flash of blood in the tube to show that you're in the vein. Uncap the end of the device to draw the blood into the tubing. It then drips into the tube. In this second example, a syringe is attached to the tubing. Pulling up slightly on the syringe draws the blood into the tubing. Be aware, if it fills too slowly, it can clot. Let it fill the syringe until you have the amount of blood you need. Release the tourniquet. Remove the needle and cover the site with a cotton ball. Then safely dispose of the butterfly device. Remember, before you start, inform the caregiver, gather all your supplies, and wrap the baby snugly. Take a shallow approach with the needle. Be patient with the baby's tiny veins. A slight pull on a syringe brings the blood.
So that's for the step in the venipuncture in pediatric. So now we move to the
So it looks quite complicated because we're talking about babies blood sampling also venipuncture, and remember that in adults you got a good compliance from the patient. In children and also in babies, you don't really have the compliance, so you need to know in terms of how you're going to make them comply. So if you got a baby or small child, you can kita boleh buat macam kita bedung dia using the bed sheet or selimut and so on. So that's one way of doing that. Or you can ask parents to hold them and basically pin them down, try to stabilize the limbs that you're going to use for the venipuncture. So so not all good physician who can do venipuncture can do a venipuncture in children. So because it needs practice and also technique as well, and plus you need to make sure they quite compliant with the procedure, which is difficult in children. The one thing that I would like to mention earlier on was in babies when you use the heel, it's not really like a venipuncture, because when you say venipuncture, it's the you are puncturing the vein. For the heel, it's like you call it heel step, means that you just it's like you're taking blood sugar. So you do the capillary sampling in a baby's heel, not really a sampling for venipuncture. Okay. Obviously, before you start, you always take informed consent from parents. You explain the procedures, what is the objective, and also the reason behind taking the blood samples, the procedure. Make sure that they understand, what was the steps and the requirement needed for the venipuncture, so that they understand. If you got like 5, 6, 7 years old who understand what you're talking about, then you can always explain to them as well. Okay.
So the complication that may arise from the venipuncture, first, the baby may pain, then hematoma may occur because there is injury to the blood vessel wall, and the arterial puncture may occur too. The evidence by the bright light blood sample. Okay, so next, so we go to the peripheral cannulation. So we're going to look at indication, treatment, site, procedure, as well as the complication. Okay, so basically, the peripheral cannulation, actually, the catheter is placed into a peripheral vein for basic access for the administration of the intravenous fluid, intravenous medication, intravenous blood or any blood product, or also the intravenous chemotherapy drugs patient. Next. So this one is the clinical selection. So we're going to have different color with different size of the couch. Okay. So this one is the basic part of the IV catheter. So make sure the needle tip will be able to facing up, and the catheter tip the skin is about 15 to 25 degree angle. So the site of selection for the preparation, can choose the cephalic or basilic vein, and also dorsal hair venous network. However, in infants, dorsal hair and dorsal foot veins are usually easier to access compared to the cephalic or basilic vein. Okay, this one is the picture of the cephalic vein, dorsal venous hand. Next. Next slide.
That was slow hang.
So these are the video for the Okay, so that's for the steps in the peripheral granulation in pediatrics. Okay, so the complication that may arise from the procedure is first pain, and then the arterial puncture may occur, and also thrombophlebitis, but it's rare actually, thrombophlebitis. So I think that's all for the puncture and the peripheral granulation procedure.
All right, good. So basically, the technique is just the way of the technique, really. So one hand is for stabilizing. So if you got small baby's hand is quite small, so you can always use your whole. If you are right-handed, then you can use your left hand to hold the patient hand and stabilize the patient hand. I don't know whether you can see if I demonstrate to you how we normally do it. So I got my daughter with me at the moment, so I can use her as my guinea pig for the time being. Come on, yeah, kejap je. Yeah, ni sini. So I'm going to show you. So the hand is like this. So when I'm done. So the way that you hold the hand, so you can use use the two C's with your thumb and also your pointing fingers, and then put it like that. One on the we call it the wrist, and then one hand basically holding the digits like that. And the other three fingers basically holding the rest of the fingers, and so you can hold it and you can stabilize that quite well. So and then you can see the veins there quite nicely as well. So in the small babies, what you can do is you can always gently squeeze the hand, open and squeeze, so that you fill up the veins. So those are the technique of holding the patient's hand. Okay, the two C's and the three fingers. This is for small children and small babies. Obviously, if the patient hand is quite big, then you probably need another pair of hands to help you out anyway. So stabilizing the hand is very important technique to know as well, and obviously to practice as well. So if you got sister or brother yang kecil tu, just practice on them in terms of two of the C's and the three fingers. So for me, venipuncture, you can use the needles, you can use the butterfly needles, or if you're happy to use the branula, then you can use the branula and then drip the blood into the bottles with the branula. So there's other technique as well and other stuff as well. Obviously, the more you practice, you will have your own preferable method to do venipuncture or blood sampling. Okay, so yeah, I think that's all in terms of venipuncture and peripheral cannulation anyway, because there's not much that we can do to demonstrate unless if we are doing it physically, then we can you can observe more and more. But I think that video is very helpful as well. And obviously you need to know the way, what to prepare beforehand before you proceed with the procedure. Okay, thank you. Okay, so we can share hand. Finish. Right. So next will be Abe kan?
Yeah, I will explain about the blood culture and sensitivity.
Okay. Baik. Thank you.
Can you see my slides?
Yes, we are. I can.
Yes. Okay. Okay. So this is the outline of my presentation. I'll start with introduction, explain about the equipment, and last one is the procedures. Okay. So the purpose of blood culture and sensitivity is to detect an infection in the blood and identify the true pathogen to diagnose and treat sepsis. Okay, bear in mind that in blood culture and sensitivity, they can only detect bacteria and fungus. So virus cannot be detected via the blood culture and sensitivity. Okay, for technique, so this is very highly important in taking the blood culture. So the technique is aseptic technique. So it is more more aseptic compared to the venipuncture just now. Okay, for indication, so for indication is it is indicated for patient who has any sign and symptom of sepsis. For any patient who has any sign and symptom of sepsis, and it should be taken before the empirical antibiotic administration to the patient, so that we would not get the false negative result. Okay. So let us revise what is sepsis. So sepsis is defined as life-threatening organ dysfunction caused by dysregulated host immune response towards an infection. So any child who is suspected of proven infection that has any of these two clinical signs should be treated as sepsis, and sepsis workup should be done for the patient. So among the four signs are temperature, hypothermia less than 36, hypothermia more than 38.5, tachycardia or tachypnea, altered mental status, and reduce in peripheral perfusion and prolonged capillary refill time. So any patient who has any of these two clinical signs should be treated as sepsis, and blood and culture and blood culture and sensitivity should be taken prior to antibiotic administration. Okay. So that is for an older child sepsis just now. So for neonatal sepsis is the sign and symptom is a little bit different. So they have temperature instability, which is hypo and hypothermia. Skin manifestation is they might have poor perfusion, mottling, pallor, jaundice, erythema, or petechiae. Then for the behavioral changes, so this one could be detected by the parents or the caretaker, such as the child suddenly become lethargic, irritable, or change in tone. And then for the feeding problem, they might have poor feeding, vomiting, diarrhea, or abdominal distension. For cardiovascular, they might have tachycardia or hypotension, but hypotension usually is the late manifestation of sepsis. Therefore, we couldn't we should detect it early by the signs just now, like tachycardia, tachypnea. Okay, for respiratory, they might have tachypnea, cyanosis, or respiratory distress, and for metabolic, the neonate might have hypo or hypoglycemia, and they might have metabolic acidosis. So these are the signs and symptoms of neonatal sepsis. Okay. So before starting any procedures, first you should, as Dr. Azamin has explained just now, we must introduce ourselves. Then we must confirm the patient's identification. So it's very important. Then the third one is briefly explain about the procedure, how it is done, and its complication, such as hematoma, pain and hematoma. And then for the last one, gain informed consent. Okay, for the equipment of the blood culture sensitivity, so these are the equipments. So first we must have the shrink and the needle. For the shrink, the older patient or the older child usually needs 10 mils per bottle. So here we can see the aerobic and anaerobic set. So aerobic and anaerobic set ni usually is for the older children. Meanwhile, pediatric bottle is for the younger children. Okay, for the aerobic and anaerobic set, each of the bottle should be filled with 10 mils of the blood. Each of them should be filled with 10 ml of the blood. So during blood taking, we should take a larger larger shrink for like 20 mils shrink. Okay, then we need the tourniquet. Then this is called disposable dressing set. Then this is called hexidine, glove, sterile glove, disposable plastic apron, the cotton ball, and this one, the tape. And the most important thing is the blood culture bottle. So this aerobic and anaerobic bottle is for older, and pediatric bottle usually we only aerobic bottle or this pink bottle. Then the sharp bin is to discard the sharp needle. Okay, so this is the equipment. Okay, so it is important that we have to know the steps of hand hygiene. So this is the WHO steps for hand rub. So you have to know it. Then washing hands also about 11 has 11 steps, and you have to know it detail to prevent any skin infection infecting the blood skin flora. I mean. Okay. Then surgical hand rubbing technique also is used. This is quite different, whereby we hand rub from our hand up until the elbow, up until the elbow. Okay. For the procedure, I will just explain, and later we'll see the video. Okay, first we must perform hand hygiene by hand rub or hand wash. Then open the dressing set. After that, after opening the dressing set, we should arrange all the items. Plus, we take out 2 needles and shrink, and also sterile glove. And then pour the chlorhexidine gluconate in 70% isopropyl alcohol to soak the cotton ball. Then we remove the caps from the bottles and scrub after removing the caps from the bottle, we scrub the rubber band surface of each bottle with alcohol swab. Okay, then once again we perform hand hygiene and we go to the patient. So position the patient arm in a comfortable extended position that provides an adequate exposure. Okay, so regarding the site of the blood culture, so it can be taken just like vena puncture just now, at the dorsal part of the dorsal venous network, or dekat at the cubital fossa side. And we apply tourniquet 4 to 5 finger width above the vena puncture site and re-examine the vein. And then we must wear disposable plastic apron. Okay, after we wearing the apron, then once again we should perform surgical hand rub just now. That surgical hand rub is quite different from a usual hand rub, whereby we hand rub our hand from the distal part of our hand to the elbow. Okay, and then wear sterile glove. Okay, after that we clean the site with chlorhexidine soaked cotton ball tadi. So we usually in HDA they use circular motion, clean the site in a circular motion from inside to outside, and then we wait till dry before blood taking, and then we put a clean sterile drip which is provided in the dressing set, disposable dressing set. And then after that we draw blood. So regarding the volume of the blood that we should draw, so for a younger patient, usually 1 to 3 ml, and the bottle that we use is the pink bottle, which the pink bottle. And for older children, usually 8 to 10 mils for each bottle, aerobic and anaerobic bottle. And then after drawing blood, release the tourniquet and remove needle. change to another needle before filling the blood into the bottle and to minimize contamination from the from skin. And then apply pressure to the site with a clean gauze. Discard the used needle into the sharp bin, and last but not least is thanks the patient. Okay. So this is table regarding the total volume that should we draw from the patient. Okay. Before send after the last step is to check the label forms for accuracy and do not cover the barcode on the bottles with patient's label. And lastly, place the hazard bag and send to the lab with the request form. Okay, so this is the video. So this video has no sound. We can see here the equipment. This is first you have to introduce yourself to the patient. Check the ID of the patient and perform hand hygiene before you take out the equipments like sterile dressing set. This is the sterile dressing set. So the blue one is aerobic bottle, the orange is anaerobic. Next, pour the chlorhexidine solution to soak the gauze. Prepare the needle. And sterile glove. So this part is so important. You clean the rubber band of the of each bottle with alcohol swab. Then you can inspect the vein that you want to puncture. So this is surgical hand rub. You can see that the doctor did the hand rub up until the elbow. Then wear the sterile gloves. that you clean and drape the site that you want to puncture. So this another technique that you can use, back and forth. So other than back and forth technique, we can use the circular technique. We clean the side from inside to outside in a circular motion. This is for draping. Okay. So the technique for is just the same as venipuncture. So not necessarily we use this butterfly needle. This needle. Check the label and forms for accuracy. Do not cover the barcodes and place the biohazard bag and send to the lab with the request form. Okay. Then done. For the complication of blood culture and sensitivity, just the same as the venipuncture. So patient can experience pain and hematoma at the site. That's all. Thank you.
Okay, thank you very much. Basically, taking blood culture between adult and pediatric is no, there's no major difference. There's no major difference apart from the bottle culture. So normally in adult you use the anaerobic and also anaerobic and also aerobic blood culture bottles. For pediatric, we only have one, but you can always use the anaerobic and also aerobic blood culture bottles if you got a big child, like probably 6-7 years old, who you think that quite big, quite chubby, and it's very easy to get bloods from them. You can use the two bottles culture. For the pediatric culture, normally you expect if you think that you cannot get more than 5 mils of bloods, then they use the Paeds blood culture bottles. But if you think that you can get more than 5 mils, then you can use the two blood culture bottles. So it's not, you can use both depending on how much sample that you can get. Very important to have a aseptic technique for blood culture bottles, because you don't want to have false positive results, meaning that you take a culture, but because the step that you're taking, that you probably miss or probably there's contamination on the skin side, or there's contamination on the string, contamination on the top of the blood culture bottle. So sometimes, because of the technique is not proper, it's not aseptic, so something can have false positive blood culture yield because of our technique, especially if you're not drying the skin with the chlorhexidine properly. So sometimes you can have the most commonest false positive result is the Staphylococcus, coagulation negative Staphylococcus aureus. It's a skin colonization normally. So those are quite common in the false positive result. But otherwise, it's the same way of you taking blood culture in adults. It's just that the technique of venipuncturing, you need to be more precautious, and also more more details. Make sure you are following the aseptic technique. Okay, so last one. So back to, sorry, is there any question from the previous two presentation that you want to ask?
I have a question.
Mm-hmm.
The smaller child, which we cannot draw too much blood, and we only use the pediatric bottle. Does mean we will have less. Since Abi said it's only for aerobic, how about the anaerobic in smaller child?
So 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 the pediatric bottles can detect both anaerobic and aerobic. Okay, but in adult you try to separate anaerobic and also anaerobic and also aerobic bottles because of the machine. So normally if you got if you got a good amount of blood samples, you want to separate so that you can put those two bottles into the different algae and in different plates and so different machine. But for pediatrics, they normally can detect both anaerobic and also anaerobic, so aerobic and also anaerobic sample anyway. So it's just that the amount of blood that you're going to come out. So if you got good amounts, you probably can use the two bottles. But if you get less amount, then you can use the pediatric bottles, and it's yielded equally effectively for anaerobic and also aerobic microorganism.
Doctor, I have a question. So is there any kind of point of age that we can differentiate between younger children and also younger and also older children?
So there's no cutoff point. Okay, so if you got a child that is like 10 or 15, you can use the pediatric bottles. The thing that will differentiate whether you can use the pediatric or anaerobic bottle is the amount of blood that you can obtain. So if you let's say if you got if you got like 5 years old, and then when you take a blood sample and you can manage to take about 15 or 20 mils, and so there's a good amount of blood sample, so you can put to the two bottles, to the anaerobic and also aerobic bottles. But if you only get 2 mils from 15 years old, then you can use the pediatric bottles. So it's about the amount of blood tests, amount of blood sample that you can obtain. But obviously, because we tend to be very stingy with our sampling. So macam kena kut sikit kan. So normally even though you are 10 ke 11 ke, normally we just take about 2 mils or 3 mils, or sometimes up to 5 mils to put into the one piece bottle. But if you can obtain more than 5 mils, more than 10 mils, then you can always use the aerobic and also anaerobic blood bottles culture for that. Tapi cuma kadang-kadang tu kita ambil sikit je because it's pediatric, so we just take small sample. So those are the orang kata the routine that we use. So we because it's Paeds sample, Paeds children, Paeds patient, we just take a small sample up to 5 mils, and usually in our Paeds ward we don't really store the aerobic and also anaerobic bottle, so we just store the Paeds bottle kan. So you rarely see the two bottles, the aerobic and also anaerobic bottles in our Paeds ward. So that's why we tend to send one Paeds culture bottle here. So normally we take 5 mils kalau dia big child. Kalau dia small child, we take 1 to 2 mils. But if you go to ED, if you got 2 bottles, then you can use the 2 bottles. If you got 1 bottle, then you just use water. Use 1 bottle, just equally effective anyway to yield positive blood culture anyway. Cuma tu lah, it's Paeds patient, Paeds ward. So you normally we just stock Paeds blood culture bottle. We don't really stock the anaerobic or aerobic blood culture. Okay, in a situation that you run out a blood culture bottle for Paeds, and so you can use the anaerobic and also aerobic blood culture bottle. So it still can be used as long as you got good amount of blood sample lah. Janganlah ambil 1-2 untuk 1 to 2 mils for the aerobic and anaerobic culture. So that's not enough lah. So you need to get more. Okay. Right, last one. Abe, kan? Nadia agak adil lah. Nadia. Okay. Tak dengar tu. Tak unmute lah.
So today I'll be talking about nasogastric tube. Okay, nasogastric tube is actually a small tube passed through the nose into the stomach for indication of GI decompression, drainage of stomach content, gastric lavage, upper GI bleeding, assessment, treatment, delivery of medication, as well as hydration and enteral nutritional support. So these are the more common NG tube that we use. This NG tube, they have the radio opaque line that we can use for us to do assessment post incision, and as well at the tip of the NG tube, there's actually a lead which will allow the tip to be stayed in the gastric due to the weight. So as usual, the preparation is literally the same. First, ask for informed consent. Before we have the consent, we need to discuss about the patient, what we want to do, what the complication, and why we need to insert the tube. So then we need to have the documentation of what size we use, when we put it, is there any complication after that. And it's most important, we need to identify the patient names and the procedure verification, notes on patient allergy or adverse reaction such as latex allergy. It can cause acute adverse reaction. And then ideally for children, they need this procedure need to be done in a safe environment because it's an invasive and uncomfortable procedure. So the child need to be in the calmest state as possible. And also for observation, we need to observe the vital sign of the children pre and post insertion to identify is there any dislocation or wrong insertion, or is there any complication afterwards. And then between the flex observation chart is actually a chart that we monitor the patient while they are using the tube. Is there any adverse reaction between the times? So after we got the consent, regarding the gastric tube size, recommended for newborns, for feeding we use 6 French, for decompression 8 French, and then infants and children up to 5 years, feeding 8 French, decompression 8 to 10 French. Children over 5 years, we use 8 to 10 French for feeding and 10 to 14 French for decompression. However, we need to have special consideration for such selection in children with developmental delay or any other abnormality. We need to consider smaller tube indicated. So these are the colors coding tube, which is the green one is the 6 French for newborns, the blue for up to 5 years, and then the black and white up to 5 years and above. Okay, so when to start? Before we start inserting, we need to put the child in the most comfortable position and most approachable position. Hold the infant or child during the insertion because they may move and may cause wrong insertion. So we may need distraction therapy in smaller children, such as the moms or the guardian may carry their bubbles or their action toys. And if available, child life therapists, the play therapists may be involved. But actually, I've never seen involvement of play therapists before. So the positioning in infant that can't sit yet, so we wrap them in the sheet or cuddly as per diagram in supine position with their head elevated for about 15 to 40 degrees. For infant that can't sit on older children, we put them in a seated position and then we hold their head back so that they don't lean forward. But even though we hold their head, we need to avoid the neck to be extended. So it's like a neutral straight position. So these are the equipment needed. We need string to aspirate the stomach content as well as to insert some air to detect the tip of the tube. The tube itself, the stethoscope for assessment post-insertion, plastic apron, glove, adhesive for sterile technique aseptic technique, and pH paper to test the aspirate that we'll take after insertion. So procedure, first we need to measure the tube, how long, how far we need to insert the tube, where we measure from the tube, from the tip of the nose to the bottom of earlobe until the midpoint between the sternum, or between the xiphoid process and the umbilicus. So the length of insertion should be noted in the child's clinical record lah. They have 50, 60, 70. So and then after we have measure, we lubricate the end of the tube to make it easier to insert the tube. Lubricate the end of the tube with water-based lubricant, or activate the lubricant of polyurethane silicone tube by following the manufacturer's instruction carefully. Different tube may have different instruction. So when we have lubricate the tube, we need to determine which side of the nose ring that we want to insert. Examine the nose ring for patency, determine best side for insertion. If age appropriate, we can ask the children themselves lah, is there any sinusitis, any inflammation, or which nose ring they prefer. In younger children, gently occlude each nose ring separately and insert the tube in nose ring with the best airflow. So when we have choose our nostril, gently insert into one nostril and advance tube posteriorly, aiming the tube parallel to nasal septum and superior surface of heart pharynx. So in order for the tube to advance to nasopharynx, allowing the tube to sink into the fascia of esophagus and stomach until the major marking is reached. So slowly inserted it. So if the children age is appropriate, we can ask them to help us by slowing. So by them slowing, it actually allow the tip to advance further inside the patient. For infant or child with instant gag reflex, swallowing a small sip of water may enhance passage of tube into the esophagus. So while we insert, we observe the infant. Is there any excessive gagging, coughing, wheezing, apnea, or color change during placement that may suggest that the tube is not in the esophagus but maybe inside the trachea? If we suspected that, we need to withdraw the tube and re-advance when the child is stable and comfortable. Don't re-advance immediately. So if resistance is met, withdraw the tube 1 to 2 cm and rotate it slowly with downward advancement directed toward the closest ear. Never force the nasogastric tube, because sometimes if the resistance is met, it's actually due to the coil. So if we rotate it slowly, it's avoid the coiling of the tube. So that's what when we have insert the tube until the marking, then we need to assess whether it's successful or not. So how we assess it? We note the external length of the tube at the nostril, and then we gently aspirate a small quantity of gastric fluid from the NG tube with the string, the 3 ml string, and check the pH. For usually, supposedly the pH is about 1 to 4, because this is a safe pH for gastric content. However, they may have some variation if the patient is on PPI or on any medication that will alter the gastric pH. After that, we need to ensure the external length of tube remains unchanged from step 1. Then we anchor. Anchor the remainder of the tube with tape. We can use either this tape, or some even use the tegaderm. So anything that available lah, and secure to the patient. So we may consider X-ray prior to commencement of feed on all new incision at risk patient. So maybe if the pH testing give false negative for initial information, such as like I said, patient on gastric pump inhibitor, on gastric continuous feed, or with diminished or absent gag reflex, or in patient with altered level consciousness, where we can't really take decision clinically. So we need to consider doing a chest X-ray. So if we do a chest X-ray with patient with nasogastric tube in it, it should be like this, where the tube is straight, there's no coiling, and then the tube does not does not go to the trachea or bronchus. It's straight to the gastric, and the tip is inside the gastric cavity below the diaphragm. Okay, so after we have assessed it and we sure that it's successfully inserted, this is the post-procedure, the algorithm of what I'm talking about. Just obtain the aspirate, and then if the aspirate is through, and then we uh, put the tape. So that's it. Then we can start the feeding. However, since every procedure we may come with complications. So for nasogastric tube, the complication that can occur is pulmonary intubation, where we insert the tube to the trachea instead of the to esophagus, and it also can cause pneumothorax, tube displacement, aspiration, nausea, retching, vomiting, nasopharyngeal discomfort due to foreign body incision, rhinitis, sinusitis, nasal erosion, and ulceration, especially if that patient have latex allergy. And then otitis media, nothing of the tube, esophageal perforation, gastroesophageal reflux, and as well might as well produce fistula formation. However, the complication is not a common thing to happen. Then we should not perform any nasogastric tube insertion without consultation with the medical consultant responsible if the patient is in the post-operative period or in known to have structural abnormalities such as choanal atresia or patient with trauma to the head, there's skull fracture, suspected spinal injury, known or suspected esophageal varices because it may cause bleeding after that. Patient with stricture, obstruction, or suspected nasal, maxillary, oropharyngeal, or esophageal trauma, base of skull fracture, bleeding disorder. Because if they have bleeding disorder or varices, we might induce bleeding and cause a patient to go into shock. If they have skull fracture, we might put the tube into the brain. So that what thing that we need to be take caution of lah. So that's all for me. Any question?
All right, guys, you got any question? So the main thing about insertion of NG tube is, and always, you need to measure first. So make sure you got the right measurement. So there's a few kind of measurement you can use from the nasal to behind the ears down to the different sternums, and there's also other kind of measurement as well. There's a straight measurement as well. So there's a few measurement, but which one do you use? It doesn't make any difference because the length is not change. It's not different. It's not no significant difference with the length anyway. When you look at the X-rays, so before that, if you can get aspirates from the gastric for the gastric content, that's good because you can test for the pH. But sometimes if the patient on PPI already, or if the patient been on the gastrojejunal feeding, so sometimes you don't really get the acidic pH. So in that case, you probably need to get the X-ray to confirm the tip of the NG tube or rice tube, and making sure when you look at the X-rays, the rice tubes is straight down, and ensure it passes the diaphragm, because if it looks straight and does not pass the diaphragm, it's probably not low enough. Then in that case, you need to push it further down to make sure it's going into the gastric fundus. Okay, so that's the main thing about that. And obviously, if it is coiled somewhere, above the trachea or above the pharynx, then it could be signs of possible choanal atresia. If it curl up around the trachea, it could be the tracheoesophageal fistula. If it going to the right bronchus, then it means that it's not in the right place. So the issue about the neurovascular disorders or somebody with the reduced GCS is that you worry about their swallowing. because if they don't swallow, it means that their both of their esophagus and also their roots to the lung are open. So there is a high risk of putting down the NG tube into the right bronchus. So that's the reason. So that's why if you got a child that is crying, a baby that is crying when you put down the tube, at some point they will swallow their saliva. So swallowing the saliva, you basically closing down your airways. So by doing that, you're hoping that the NG tube will go down to the abdomen, to the gas trick. So that's the main thing about that. So the good thing now is we got this opaque line that you can detect on the X-rays. So if you got the silicone NG tubes, so it can be used up to 2 weeks. So once it's up to 2 weeks, then you need to change the tube, because it can also colonize the fungal infection and also the bacterial infection as well. So that's why you need to remove the silicone tube every 2 weekly. If you got the silk NG tube, then it can last longer than 1 month. So, but obviously it's a bit difficult to get the silk tube. Normally in KKM or in our hospital, we ask parents to buy themselves, and then we will put in on their behalf. But normally we just advise them to come to the ward or come to the clinics every 2 weeks for NG tube changing. And this is only for silicone NG tube. Okay, it's going to be a short one. I think if you've got any question, I'm happy to answer your question. But this is a procedure. You need to see them, you need to observe them, you need to assist them. What we're doing now is just a theory. It's good that we have videos for the insertion of for the venipuncture, for the blood culture, and also for the NG tube insertion. But it's still a theory part here. You still need to know in terms of the environment when you're doing these things is intense sometimes, because sometimes parents don't really have the heart to let you do it on their child. But at least if it needs to be done, it needs to be done. So the parents need to be on board with us when we're doing this kind of procedure. So what we're doing just a theory. So the best thing to do is basically, once you are in the hospital, you're going to see venipuncture going to be done or NG tube going to be done. Just be present so that you know what is the environment, what is the preparation need to be taken before this procedure take place. Okay, any question?
Doctor, I have one more question.
Yep.
Can the pediatric bottle in adults, such as in patient with collapsed vessel or difficult vein that we can't withdraw so much blood?
Well, I suppose you can use a pediatric bottle, but you always tell the lab that the reason why you're sending Paeds bottle in adult. You just explain that so that they will be very careful in terms of when they're going to put the sample into the algae, into the plates, and then you as a clinician, you need to interpret this result with caution, because sometimes they're probably not going to yield a proper aerobic sampling very well. So there's a pro and cons, but obviously if you if you don't really have good samples, then I would say you can send, but you just need to tell the lab that you're doing this for a reason, because the patient is very unwell, severely unwell. You're not be able to withdraw much blood sample from them, so that's why you send this amount of bottle. But I think the lab normally, if you don't get good samples, I think if you, I don't know, I can't remember whether you can send anaerobic or aerobic, because probably anaerobic is probably more important for you to send rather than aerobic. I can't remember which one is which, because I've not done adult for, I don't know, 10 years, 12 years. I don't really know, whether whether I'm the right person to ask this question. But yes, I think you can, but you need to tell the lab why. They normally tell you that why you send Paeds bottle, why don't just you send the anaerobic bottle. So one of them, I think one of them is much more better than, I think it's anaerobic. So if you don't really have a good sample, then I think you can send anaerobic bottles rather than aerobic bottles. I think you need to get back to Dr. Hidayah. I think the microbiologist, she probably tell you the right answer, because it never happened to me, so I don't know whether it's the right answer or not. Okay. Right, the rest of you, any other question? Haziq tadi senyap sebab bukan dia punya presentation so dia senyap, relax je, makan rendang Okay, no question, I presume. So Haziq, you got no question? Zurain, no question. Rahel, nope. Syairah, no further question. Abe, no question. Okay, semua geleng kepala. Syazwani, no. Idlan, no. It's a Sunday, so thank you very much for attending the session. So I think we will have a few more sessions. I would say all the best. I'll see you around, even though I'm not going to see you physically after this, but yes, all the best. Right, thank you. So we're going to tangguh majlis dengan tasbih for us semua. Right, thank you very much. Thank you. Assalamualaikum.
Thank you, Doctor.
Doktor, waalaikumsalam.